Hi, I'm Dr. Durusha, the founder president of the PCOS Society of India. The society is of multidisciplinary experts in the field of gynecology, dermatology, endocrinology, and all the allied specialists who look after PCOS women. We all are focused on creating awareness on PCOS, both amongst doctors and updating their knowledge. And we are also wanting to create the awareness amongst women at large for them to understand what they are having and what their problem is. In short, our organization is consisting of experts both from India, and we also have members from outside the country. It's important for all of you to be with us and join us in our endeavor to upgrade our knowledge in this field and reach out to our patients so that they have a better quality of life in future. Thank you.
Let me take it from you here. I thank my panelists, Dr. Sujata Kar, Dr. Mohammad Bhat, who are very, very busy with their clinical practice. Thank you so much for joining us. It's a pleasure always having you and looking forward to learning a lot from you guys. So today we'll be discussing PCOS and infertility. We know there is a pandemic of PCOS across the world. We have different prevalences coming from different parts of the world depending on what kind of studies are being done and what is the geographical location. We'll not be discussing that part, but we will be discussing the infertility part of PCOS. But I want to tell the audience here that polycystic ovary syndrome, we have some short-term consequences which we very frequently come across. We have patients coming to us with irregular periods. We have patients coming to us with cosmetic concerns. Then in their early adulthood, when they want to start a family, we have patients coming with infertility. But what is really neglected and what we really also need to take into consideration and educate our patients is that this polycystic ovary syndrome is a multi-system endocrinopathy and it affects lots of your systems. There is no cure for it. And later on in life, when you are heading towards menopause, and even after that, it leads to very unhealthy consequences. It leads to insulin resistance, diabetes mellitus, high blood pressure, hypertension. You can even have cholesterol problems, what we term as dyslipidemia. And you will be at a higher risk of cardiovascular events, where myocardial infarction, which is a heart attack in layman language, and stroke. And then you also have the mental health issues which are associated with this syndrome. You also have sleep apnea, which in itself is a high risk for developing metabolic syndrome as well as other cardiovascular problems. So in short, let's not only focus on the short-term ones, though our today's topic is one of the short-term effects of polycystic ovary syndrome, but be sure that you are on a lifelong health plan as far as your PCOS is concerned, and you are under a supervision of a good PCOS specialist, endocrinologist, or a gynecologist through your life. So let me introduce our worthy panelists, and I again thank them for being on the panel. And can I have the slides for Dr. Sujata and Dr. Mohammed? Yeah. So Dr. Sujata Kar, I'm sure, needs no introduction. She is a practicing gynecological endoscopist and an IVF specialist. And polycystic ovary syndrome, of course, is her area of interest. And in addition to that, stem cells and gynecology and proteomics of male infertility. She's been the best graduate and has won 7 gold medals in her medical school. She's been credited with the first IVF baby of Orissa, first TISA, frozen embryo, and laser hatched babies of Orissa. She's won various awards, which include Parichay Award and Devi Award, and also Brand Icons Excellence Award for Best IVF Center in Orissa. Lots of publications which are mainly focused on fertility and PCOS. So she has contributed to various chapters in books and newsletters. I mean, that goes without saying. She's an excellent reviewer of international journals. And currently, she is the Vice President of Indian Society of Assisted Reproduction and Executive Member of the PCOS Society of India. And she is the Chairperson of the Orissa chapter of ISAR. Welcome, Dr. Sujata, and she's a very good friend. I forgot that. Welcome and thank you for being here.
Thank you, Sabahat. Thank you.
Can I have the next slide, please? Dr. Mohammad Bhat, he is from Srinagar and he is currently Assistant Professor of Endocrinology at Government Medical College Super Speciality Hospital, Srinagar. He's a very, very busy practitioner, Fellow of American College of Endocrinology, Fellow of Royal College of Physicians of Edinburgh. He's Fellow Research Society for Diabetes in India and life member of various endocrine societies, and receiver of Award for Diabetes India 2021 and RSSDI 2021, recipient of Islamic Development Bank Scholarship, more than 100 international and national publications, and with lots of citations, and his special interests are diabetes and thyroid. I think PCOS got left out there. Thank you very much, Dr. Hayat, for agreeing to be on the panel. So we are going, before we start the discussion for the audience, we are going to have a pre-audience poll, and we will have that audience poll again at the end of the discussion. So we really want to know whether, our discussion made any positive effects and whether your doubts got cleared towards the end of the discussion. So as you know, that our topic for today is subfertility or infertility in PCOS. So my question to both my panelists, one is an endocrinologist par excellence, another one is an IVF specialist, a reproductive endocrinologist. How do you see PCOS and infertility in today's times? And of course, I also want to compare because we come from two different regions. And sometimes you have ethnic variations, as we understand in PCOS presentation, and also for complications. So I would like to take your take from both of you on PCOS and infertility. Dr. Sujata, I think we can start.
Yeah. Thank you, Sabahat. Thank you. So, yeah, PCOS and infertility go hand in hand. The moment you see a PCOS woman who's an adolescent, you counsel them, there's a chance that you will also face fertility issues.
Yeah.
So I would say at this time and day, with the lifestyle and the increasing weight and many other metabolic factors that are also associated with PCOS, infertility is a major part. We have to deal with it day in and day out. Having said that, infertility patients, PCOS women, if they come initially, we can counsel them and we can induce some lifestyle changes. And often, I wouldn't say very often, sometimes they would also, there's a good chance that they would also get pregnant spontaneously. I think this is what you were asking.
Yeah. Dr. Hayat, let's take your opinion on how are you seeing PCOS and infertility. I'm sure there is an overlap. You will be getting more of endocrine part, but
we are seeing a lot of bidirectionality in these patients, PCOS with metabolic syndrome. And there are many patients who have metabolic syndrome and develop secondary PCOS. And there are many patients who have PCOS and have associated metabolic syndrome to the tune of, say, 20 to 30% in several studies. And now many studies have quoted infertility in PCOS as high as 70%. So if we have the obese phenotype of PCOS and we address the metabolic issues together with PCOS itself, so definitely lifestyle changes and other treatment parameters which will be taken care of, which we will discuss, can ameliorate the infertility prevalence in these patients.
So we understand that, yes,
but
there is
Sabahat, I feel that maybe Dr. Bhat is right, that ideally, in the first line treatment of infertility, either ways is lifestyle changes, but it's so difficult these days. That's why when I started, I said that very small number of women are actually going to go that path and are going to, be able to get to a point where they have taken care of their metabolic syndrome and their hyperinsulinemia, and at least spontaneously ovulate once in a while where they can get pregnant. So we can maybe do that if they're really young, leave them for a year or two.
Very motivated also, not only very young.
Yeah,
I think it's tackling this global warming and having lifestyle modifications, starting
yeah,
them and then persisting with that is, I think, it is synonymous.
yes,
We are seeing an epidemic of heat, and it's like so hot. It's never been like that in Kashmir ever. So I
I
mean, that was
agree.
just yeah. That was just by the way. So we understand that PCOS is a major cause of infertility as far as ovulation problem is concerned. Above and beyond an ovulation, you see, whenever females are getting irregular cycles, it's more or less almost suggestive of an ovulation problem, that they're not ovulating on time. So other than that, are there any other parameters that cause infertility in this population? Okay. So Dr. Sujata, what I was basically asking is that above and beyond an ovulation problem or anovulation, are there any other factors that cause infertility in these women?
I think basically it's a vicious circle of all the things, which ultimately leads to infertility. So obesity, hyperinsulinemia, and hyperandrogenism, they're all interconnected. So it's a vicious circle that would lead to an anovulation. Other than that, also we know that there are some factors which is not well understood that leads to early pregnancy loss in PCOS women, maybe a raised LH. The mechanism of that is not well understood. That is another factor which contributes to these people being infertile or having recurrent early pregnancy loss.
Dr. Hayat, your take on insulin resistance in
I would
in
suggest that there is a causation is multifactorial. It's at the central level, that's at the pituitary, the adipocyte level, and even at the ovarian level. Now, if you see at the pituitary level, what we are seeing that once you have insulin resistance and hyperinsulinemia, and in the face of increased adiposity, you have what we have a decrease in the sex hormone binding globulin, which in turn exerts a feedback on free testosterone. So you have very high free testosterone, and this free testosterone acts as a co-gonadotropin with insulin. So it sort of is adding fuel to the fire to hyperinsulinemia and insulin resistance. So that will sum up what your pulsality and amplitude of the LHRH is lost, and the frequencies and amplitude. That's how you have that LH surge and high levels of LH. And at the ovarian level, you will have increase in the thecal drive, and there is also a effect on the star protein production, and there's also an effect on the oocyte recruitment production because of the what we have, the AMP kinase pathway, which is subverted. And at the adipocyte level also you have, as I said, a decrease in the SHBG, which is increasing your testosterone. So multiple levels causing multiple mechanisms, and to sum it up, insulin resistance, hyperinsulinemia, decrease SHBG, increase free testosterone, ovarian issues, and there's a peripheral sort of a increase activity at the ovarian level, but at the central level there is pulsatility of LH is affected.
So high AMH is, again, do you see it as a problem, Dr. Sujata? A patient walks into your clinic and has an AMH of 16 nanogram per ml. You're happy or you're concerned?
See, these ultra high AMH levels definitely is a point of concern, because in cases of PCOS, it's not always that the high antral follicles that we find morphologically in the ovaries, not necessarily they always correlate. It's also the fact that each follicle secretes abnormal kind of a AMH, and the microenvironment in each follicle is extremely abnormal and disturbed because of this high AMH level. So the follicle is simply not able to respond. It's unable to develop FSH receptors and unable to respond to any kind of stimulation. So it's a total inhibitory effect intrafollicular milieu becomes
It's
like that.
disturbed.
So, like you said, if the AMH level is very high, I'm certainly concerned, and that would give me an indication that probably this patient is not going to respond easily to the stimulation
Ovulation
that
induction.
ovulation induction stimulation that we will be giving to her. That's a typically very difficult category of patients to manage.
So in that category of very high AMH, which has an inhibitory effect on FSH as well, and there's a disturbed milieu, then we have oocyte competence issues, you have poor quality embryos. I mean, that comes later, of course. But would you rather counsel them for going into a very controlled IVF, or would you give them a trial with gonadotropins or oral ovulogens? I see most of them with a very high AMH, almost majority of them will not somehow respond to oral ovulogens.
No, but I would certainly give them a trial. Of course, that will be based on patient history and you have to individualize. If somebody who's treatment naive has never undergone ovulation induction, it certainly makes sense to give them metformin and to induce lifestyle changes. If necessary, give them oral pill. I mean, that of course depends on the on their window of opportunity for pregnancy. If they are very young, we can certainly do all these adjuvants, lifestyle changes, etc. Although there is no direct link that it can get the AMH levels down, but we know now that metformin given for some times can have an impact on abnormally high AMH. And I would certainly give them a trial. It's possible that they will need a higher dose. Like, let's say, the letrozole, the standard dose is around 5 milligrams. And I would start with 7 always. And you will be surprised as to, there are so many variables in a patient that you can't take AMH as one single parameter and say, no, she will not respond. So I'll give it a trial. And if she doesn't respond, I would increase the dosage and all that. And if the IVF will be the last case scenario because they are going to have face difficulty with IVF also. If you know.
Sometimes they walk in and they have obviously done a bit of medical shopping as well. So they'll come and they'll say, Doc, my AMH is very high and I was told that I should directly go for IVF. And if they give me gonadotropin, then, for IUI cycle or for otherwise, for ovarian stimulation, then I might be out of control. So, I mean, sometimes patients do come up. That's why that question.
Yeah.
So, Dr. Hayat, I would like to know a patient is infertile and she has PCOS. And we have done though we don't do a biochemical analysis in all those patients, but we have done a free testosterone and we have done androstenedione. I'm sure you will not agree to doing androstenedione, but I will like to tell you, I think I told you in E3 seminar also, Dr. Hayat, in some of my patients who are really very, very hirsute and, free testosterone comes normal. I mean, that I do for research. The androstenedione levels done in morning samples, good labs, come really very high. So is that a point of concern? Or so this is an infertile patient who is hirsute and she is ovulating or she needs ovulation induction, but her male hormones are high. So can we start ovulation induction upfront, or would we like to bring down the male hormones and then go ahead and try to get them pregnant?
Yeah, I got to a point. Last time also we discussed this. And before that, I just had a small query about this AMH. We are seeing so many local laboratories doing this AMH, and the assay of AMH is not standardized very well.
Not reliable.
And every lab is now doing AMH, and many times we see patients of classic PCOS with low AMH. And it's very difficult sometimes to really ask them to repeat it again, and it costs $1,800. And other important factor that has to be kept in mind, sometimes we come upon occasionally granulosa cell tumors of the ovary who are very high AMH. And though AMH is a good marker, as Dr. Kar rightly pointed out, but the way the labs are mushrooming here, we have to always take it with a pinch of salt while we are investigating our patients, because every local laboratory is doing AMH. I don't know. And we are getting so many patients of PCOS now with low AMH. and we're trying to figure it out. Regarding your this query about androstenedione, you are right. If you are dealing with some patients, free testosterone actually is not standardized well in India. There are only few labs who are doing free testosterone, and androstenedione, as from an endocrine point of view, we rarely do in our patients of PCOS. But you are right. If you have a patient who is very hirsute, has high androstenedione levels, it is better first to put on anti-androgens before going for the actual treatment.
Dr. Sujata, that question again makes sense because we understand that PCOS and all the complications in male and female offsprings will start with a hyperandrogenic in utero milieu. So have we ever come to a consensus as far as hyperandrogenic PCOS women are concerned that we really have to get the androgen levels down before putting them on ovulation induction? I don't think we
No,
yeah.
no, actually, the preconceptional optimization, as they call, a lot of studies have been done, and it has been shown quite well that because we are only looking from the point of view of ovulation induction. Like you raised a different question about whether the hyperandrogenic milieu when the patient gets pregnant, how that is going to impact the woman. So I don't think there are any studies to show us that, because the standard studies and the standard evidence shows us that as a preconceptional optimization,
Yeah.
lifestyle changes, and maybe you can put them on oral contraceptive pill for about 3
Yes.
months. That would do both
Yes.
the jobs,
Yeah,
or you
that
could
would
do both.
yeah.
Or you could do both, because lifestyle is absolutely necessary. OC pill cannot take care, anti-androgen cannot take care of the what
Lifestyle things. Yeah.
lifestyle can do.
Yeah.
So yeah, your question is pertinent, but we really do not have any guidelines, or we don't have any.
Yeah, that's why I thought that, we are talking so much about this. We're even talking about a male PCOS phenotype. And then we are
Yeah.
saying it probably started in utero in his mother's hyperandrogenic milieu. So then why have we really not looked at why we are not able to control LH before we do of course in that subset of population where we have advantage of age and where we have a good ovarian reserve, so we can easily put them on a couple of cycles. I think 2 months of continuous oral contraceptive pills should bring down androgens
Yeah,
very
that used to be
nicely.
standard. In fact, couple of years back,
Yeah.
it was absolutely standard to give 3 cycles of oral pill before starting them on the ovulation induction. But that does not seem to be holding true where evidence is concerned. And also, I think the serum free testosterone levels, and they're very dynamic. I'm sure they keep changing. And so if you put them on oral pill for some time, and I'm really not sure, I have no idea. I'm sure within a month or 2 or 3 months, again, it's going to get back to its baseline
So
level.
my standard for these patients who have like very high, who are clinically hyperandrogenic, they're very hirsute, and they have high androgen levels, I do put them on a 3-month continuous oral contraceptive. I mean, anyone, not necessarily Cyprotron ones. And then when you recheck, usually at the end of 2 or 3 months, they have come down. Now, whether same lab, same, sample, so it does help in a way. So, I mean, I think that is something that could be explored. What is your take on high LH? Normally
again,
FSH and
high LH
LH, I keep telling patients that you don't need, I keep telling doctors also, it's not a part of PCOS evaluation. But sometimes patients do walk in with an FSH, LH and everything. And you see that there is an elevated basal LH, which is,
So see, I think largely, I don't remember the last time I did a LH level for a PCOS woman for ovulation induction. I might do it for a IVF cycle. No, for an IVF cycle I might do, but again, it's not important at all. So I don't think I ever do at all. But if you find a high LH, I would still ignore it unless there's a problem with ovulation induction. Or if she has, early pregnancy losses, I would tend to ignore it, Sabahat. That's the truth.
Okay. Yeah, because I sometimes, I've seen people give antagonists to get that LH down.
No, I don't do all that. I mean, you could, if it's an IVF cycle, yes, might give it for 3 days or so before
So
actually going in.
what is that range of LH that concerns you in an IVF cycle? A basal LH level that would be of
More
concern.
than 10, more than 10 maybe. I don't do it routinely as a practice, so can't comment too much.
Okay. So Dr.
About
Hayat,
androstenedione that you had asked.
Regarding this androstenedione, which you said,
Yeah.
in our practice, what we do if our PCOS patient has a normal testosterone or a free androgen index, then we do androstenedione. Otherwise, we routinely don't do. And regarding LH, if we have a patient who comes first time to us as PCOS and we have to see for other causes, that time we do LH and we might also do 17 alpha hydroxyprogesterone for non-classic CH to rule out. But as far as ovulation induction, it's not recommended. We don't do, as Dr. Kar rightly pointed out, it's not
Yeah.
necessary.
Also, if I'm not mistaken, isn't androstenedione adrenal androgen?
yeah, it is,
So
but
that
very
shows us
rarely they
the
do
adrenal
see.
component.
Because sometimes you can have both ovarian
Can
and
have.
adrenal androgens high.
Yeah. So some people tend to give, I
Marginally
think,
elevated, even DHEAS can be there in PCOS.
yeah. So some people, if they find elevated DHEA and androstenedione, they give this thing steroids. But I
Steroids.
don't have any idea about that. I don't ever do it. I don't do the test only, so I have no idea if it's
No,
elevated.
I mean steroids as well as I don't give steroids, but I would say that since our population is ethnically a little different, that's why I was trying to bring it up again and again that this subset of population is showing. I mean, I don't have the analysis as of now, but I'm seeing in my PCOS population, I'm collecting that data, that we do see people who have testosterone levels are normal, but androstenedione is elevated. So, I mean, of course, there is a very small subset of population of PCOS who will have adrenal androgens
Components.
higher, adrenal components. But maybe that's also one part of the syndrome. So let's move to the treatment. Of course, lifestyle modifications in everything that PCOS causes is the first line treatment. So whatever treatment we discuss today in the form of pharmacotherapy, medicines or surgery or IVF, lifestyle always has to go hand in hand. So what is your take on lifestyle and fertility in PCOS population?
So I think, like you said, it's integral. And at whatever stage you see a PCOS patient, let's say that you see her after
Anything.
5-10 years of infertility. So, and then by the time she's already 30 years, 32 years, every damn doctor since she was age of 13, 14 has told her that you need weight loss, you need to do exercise, this, that, and the other. So that is a difficult area. But as healthcare providers, it's my duty to tell each PCOS patient at whatever stage they come and for whatever they come, to inform them that this is a lifestyle change required for everybody, but for you or for the PCOS woman, it is also required, and you need to learn that. So even if they come in for an IVF cycle, I said at least start walking half an hour every day if you've never walked. If you have walked earlier, then increase it to about 1 hour every day. So some kind of lifestyle changes and some kind of a minimal food advice, diet advice, minimum. Stop maida or stop sugar, something like that for at least for a couple of years, like that. Some advice
A basic minimum.
Try to give them, although they have had this drummed into their head by the time they come to us for infertility.
Yeah. Dr. Hayat, what is your experience about lifestyle being taken up by these patients or any set of PCOS patients seriously? Are they really doing it?
Am I audible? There's an azan going on.
Yes, you're audible.
Okay. Well, there are there's a spectrum. Now, you have a patient who is newly married and has obesity and PCOS, and if you talk to them, the couple, and they are willing to go an extra mile. And it has been shown that lifestyle modification can help. 5 to 10% weight loss will. There are studies which have shown fertility has improved. But as Dr. Kar rightly mentioned, if she is seeing patients at the end of the road, fag and 35, 30, their lifestyle modification wouldn't help. They would need actually treatment. They have been hovering around the places for so much time. But this is true for patients who are at the initial stage of diagnosis, and if obesity has been shown with associated with subfertility. So if obese PCOS phenotype is there and they do at least 150 minutes of exercise 5 days a week, or 2 non-consecutive days they do strenuous training exercises and create an energy deficit of at least 500 kilocalories per day, the chances of fertility improve. And it has been shown that even pregnancy rates are more once they do lifestyle modification. But having said that, patients at the end of the road, there you have to offer them treatment. That's very important.
Yeah, treatment, of course, but I feel that higher their weight, the more obese they are, the more resistant they are to doing anything.
The higher weight, increase in insulin resistance, hyperinsulinemia, these are all bad prognostic factors for fertility. Higher the BMI, in fact, there is now an experimental modality which will, I think, discuss that bariatric surgery for infertility patients of PCOS who have more than BMI of more than 35. So it's also coming up. So definitely, higher the BMI, lesser the chances of fertility.
And now is the era of semaglutide.
Yeah, GLP analogs.
And now semaglutide has been surpassed by tirzepatide.
Yeah.
Are you using it? That was my question for later, but now that it has popped here,
semaglutide we are using over the OTC as off label, and even we have started using dapagliflozin in very obese PCOS patients. Semaglutide also, though it is not FDA approved, but definitely there are pleiotropic effects. I think now once semaglutide will be surpassed by tirzepatide, which is not available in India as yet, but definitely these are going to affect. These are going to be used in PCOS, metabolically this associated steatohepatitis, and all these conditions now.
So, you any experience about, now that we have embarked on this journey of these GLP-1 analogs? I wanted to know about Orlistat. Any experience of using that in PCOS? I have used it in 5 of my patients who were like obese and very resistant weight loss, and they had some time to conceive. So I told them, look, I'm going to put you on something along with your lifestyle modification. Let us see whether it will help you with weight loss. And it did cause positive, as far as weight is concerned. They did lose some weight. Of course, you will be much more experienced in that. So I would like to take your experience.
We were using a couple of years back Orlistat. Then we had other form of Orlistat was Settelstat, but it caused a lot of staturia and oily stools, this Orlistat, and weight loss was to the tune of 2 to 4 kgs only. And then there was the STORM study, which showed that it caused hypertension. So it started going into disrepute. So not much is now it's not being used much. So if you see the anti-obesity market, it's a big market, pharma market, and every year we have a drug which comes with a bang and goes with a whimper. So now everyone is now focusing on GLP-1 analogs. But definitely this Orlistat was there for a decade, but it didn't make a mark as far as...
So will this hypertension be of concern if you use it for a very short period of time, like say a couple of months? Will it still be of concern or no?
That was the concerning factor. That's why later on it was withdrawn. Because
was it for long-term use or for short-term use as well?
No, if they used it for, say, more than 6 months, hypertension started coming up.
Okay. Dr. Sujata, you used any of these GLP analogs or?
No. I have no personal experience at all. I think it is for the endocrinologist, and in case I find it. But then, of late, I have started advising bariatric surgery for people who are 35 and more, or have comorbidities like hypertension,
At 30.
or glucose intolerance and all that. Because, you see a patient, and, somebody who's like BMI 32, 33, 35, 40, that just giving them some advice is not going to help them at all. They need a targeted, multi-pronged approach. So they also have to consult a diet counselor, an exercise counselor, and blah, blah. So it's not going to be easy.
And
So
that's
it's
the
unfair
BMI
on our
at
part.
the start of pregnancy. What will it be at the end of the pregnancy? Obviously, if you don't.
Yeah. No, even to recruit them into a IVF program or recruit them into an
Yeah.
ovulation induction program.
Yeah.
So
It is
if
criminal.
they have time in hand, then these days bariatric surgery is come of age. It is become safer. People are doing a laparoscopic approach, and also we have the ultrasound guided the balloon therapy, which is, I guess, not as good, but
Not as good.
yeah. But then these kind of options are there. So there are a category of patients whom it's just not fair. We have to give them 1-2 years and tell them that you have to take a proper, targeted, more advanced choice for trying and losing some weight.
And even after bariatric surgery, I was reading some literature. You go into a catabolic phase. So
Yeah.
even after bariatric surgery, when your weight has normalized, it is suggested and recommended that you wait for some time
For
before
at
you
least a
embark
year.
on pregnancy.
At least a year.
Yeah, before you embark on pregnancy. So now I think it's time to discuss inositols. We all know metformin is almost the holy grail. We give it right, left, and center for insulin resistance, for I would say for a metabolic syndrome kind of picture. Also for weight loss, even if they are not frankly insulin resistant, we are giving it an IVF to prevent ovarian hyperstimulation for better quality of oocytes and embryos. But I wanted to discuss inositol, and that question goes to Dr. Hayat. If inositols are really so good, why are they not used in diabetic patients, or are they being used?
See, the main mechanism of this ionositol-based compounds is that they improve insulin resistance. So basically, there's a disbalance between myoinositol and dechiroinositol, and most of the gynae people you are using it. So I remember in 2019 there was an endocrine society guideline where they said myoinositol in PCOS is as good as placebo. So now recent PCOS guidelines they have mentioned that it can be used. But the level of evidence is not that
Very low.
is very low. So from an endocrine point of view, we still don't use it much, and we take it as just a placebo.
Nutraceutical.
So, yeah. So we are not using much, and even the various associations are divided whether it should be used at all.
Dr. Sujata,
Even I have zero prescription of inositol, frankly.
Yes. Makes me happy.
Yeah. Partly because A, its effectivity has not been shown. B, it's expensive. C, it's a nutraceutical. It's available off the shelf. Anybody can go buy. Many informed patients, those who look for these kind of things, all kinds of things, whether it is green coffee or a black tea or God knows what they try. So for them, all it's available. They can just buy it. And like you said, the evidence is not there. So I have never ever picked up on inositols. It's a largely pharma driven.
But there was like so much of mushrooming. That's why I kept anytime
We have
a
now
drug rep
metformin
comes.
with myoinositol
Yeah.
tablets coming like anything. I mean,
It's
Anything.
become the standard of care, and you will see
Yeah,
all the
yeah.
patients are on metformin plus inositol,
Inositol.
and the drug reps will come. No, this works very well. And I asked one of
Yeah.
them that if it works so well, then why are you not using it in diabetic populations and promoting it with the endocrine people? That's why the question came to Dr. Hayat first, because I wanted to
Yeah.
know whether they
Yeah.
use it at all. Vitamin D.
See, vitamin D is, I think vitamin D deficiency is an epiphenomena. Everyone has vitamin D deficiency in India. And we had so many studies which showed it is associated with coronary artery disease,
With
bronchial
everything,
asthma,
almost every
type 1
abnormality.
diabetes,
Yeah.
and some now PCOS. In fact, they are saying if you treat vitamin D, maybe the oocyte recruitment improves and fertility outcome improves. So vitamin D should be supplemented in all PCOS patients, that's for sure. But I think it's an adjunct rather
Yeah.
than the main treatment.
Yeah. So I think Dr. Sujata and I are both on the same page with Dr. Hayat
Yeah.
as far as vitamin D supplementation goes. It's very important.
Hmm.
And is there anything else that we would like to discuss here? Because we are
I
almost
think
reaching the end
I
of
had
this.
what's your experience in patients once you are going, because we don't do have such experience. You are going for ART. Are you using patients using metformin in ART patients prior to ART and post ART, vis-a-vis those patients who are not on metformin, one arm and other is on the metformin? Are you seeing any differences as far as pregnancy carryover rate or failure rate in those who are receiving metformin or who are not received metformin? In a way, what I wanted to know, what's your experience about
Experience.
So see,
metformin?
I would say metformin is in our DNA. We just prescribe it for left, right, and center for PCOS women. And although I can't vouch for my own studies or experience because I haven't done any study or published it, but the evidence seems to tell us that metformin needs to be continued, and it needs in even in pregnancy and even before trying to get pregnant. In fact, if I can quote one of my published studies, we had published a randomized controlled trial on metformin alone, clomiphene citrate alone, clomiphene plus metformin. I'm saying this because you asked what is your experience. So this is a randomized controlled trial that I did myself in our center and published it. So we showed that metformin alone arm also had pregnancies, although clomiphene plus metformin understandably would have the
Better.
highest pregnancy
Pregnancy
rates,
rates.
but metformin alone also had. So for us, it's very common also. It's a really young girl, 20, 21, 22 in our country. They come like that. Also, they're young, very, very young, and they just got married, planning for pregnancy, little obesity or whatever. I would simply, without even doing even if her glucose tolerance is normal, and everything is normal, even if she has a family history of diabetes, there is a little obese, I'll just put her on metformin for about 6 months after counseling her. So metformin is something just we simply love it, I would say.
I had one query for Dr. Sabahat. Now you have patient of PCOS, she's on metformin and she conceives. How, when will you stop metformin?
The jury is still out. I remember ACOG and RCOG were always at loggerheads as far as metformin in pregnancy was concerned. RCOG was never of the opinion that it should be continued. But ACOG did say that if your patient is on metformin, you can continue and it prevents GDM and prevents high birth weight. But now, according to latest guidelines, they are saying if you are putting a patient on metformin where she is not insulin resistant, and she is undergoing ovulation induction or IVF, and you are giving her metformin where you want to prevent ovarian hyperstimulation or you want to make better oocytes and better embryos, then it is better to stop metformin at the end of the IVF cycle or when she gets a period. So if she gets a period, that means she's not conceived, you stop metformin. If she conceives, you stop metformin, unless you have given it to a frankly insulin resistant patient. But I would tell you as of now, and that's what the recommendations say, we have been continuing metformin and we haven't seen any the thing that I would say is probably PCOS women who are on metformin all along and continue into pregnancy, they do not get frankly diabetic in pregnancy. Otherwise, these PCOS women are obviously obese, majority of them. And if their metformin is stopped at the beginning of the pregnancy, they have a lot of weight gain. And
So
when
if I may
that
just
happens,
put in, sorry.
Yeah,
So if I
so
may
with
just
that, then they ultimately end up in having insulin, a high dose of insulin. While as if they're on metformin from the beginning, probably that, switch over to
Lesser
insulin is,
insulin.
yeah, yeah. So that's my experience. So it's a drug which is almost, as I said, stopped being the holy grail in the management of PCOS. We're using it, but the latest recommendations are if you're not using it for insulin resistance, you're using it for hyperstimulation or to better the oocyte quality or embryo quality, to stop it once the pregnancy happens or once the period comes.
So, if I may just add my points to what you said, Sabahat, I agree with all of it. But then I would also like to remind you all that all the publications and all the guidelines that we are reading is related to Western population, Caucasian population, that really doesn't hold true for us.
Absolutely.
We have seen, and Dr. Bhat must be, really experienced. We have like everybody is diabetic here, and now if you look at them, everybody has a family history of diabetes. So our
Diabetic
scenario is,
capital of the world. We come
yeah,
from the diabetic capital.
our scenario is totally different. We have abnormal, visceral fat. So our scenario just cannot be compared, and we cannot depend on their guidelines. Unfortunately, we don't have publications and we don't have our own guidelines. Having said that, what I would say, Dr. Bhatt, to answer your question, if my patient is on metformin and has got pregnant, I will 200% continue up to 12 to 14 weeks, first trimester of pregnancy.
That's
After
what I
that,
do practically.
if she has family history, I will certainly continue throughout the pregnancy. And if she is obese, I might continue. So my
So
criteria
there is
and
Dr. Sujata, there is no PCOS patient in today's scenario who is not overweight or obese. So let's say
There are
metformin,
many.
very, yeah.
No, there are lean PCOS also. And in those also, if they have family history, I would consider continuing at a low dose. Whatever the decision has to be taken. The fact that there are no guidelines is because they haven't seen our people. I mean, so we need to take that into account.
And besides, we know in gestational diabetes patients, the large study from South Africa, the MIG study, metformin in GDM, they showed they were given metformin from word go, from first trimester, and there was fetal outcome was not affected, and it was same, it was normal. So it's though we know that metformin crosses the fetal placenta, and it enters the fetal brain. But I take your point because few years back we would continue with metformin, and after the first trimester we try to stop. But the epidemic of diabetes, obesity, and impaired fasting glucose, which we are having in such patients, makes one to think that should we continue it or not. I think the last word is yet to be said on it, but
Yeah, but
definitely,
I think we are mostly in our population, Dr. Hayat, we are seeing so much of gestational diabetics in
yeah,
in
exactly.
uh, in LD, and I think majority of them, even if they are switched over to insulin, metformin is continued.
Exactly.
Yeah, so
We
metformin is
continue.
continued, and that, since it is very safe as far as teratogenicity is concerned, I think that's our.
I think Sabahat also the major challenge that I feel is to decide the dose of that is I feel the major challenge because I'm not knowing how much dose to give when I need to continue in a patient who is not diabetic or neither is a gestational diabetic or was not insulin resistant and all that. That is, I would say, the major challenge. There's some papers who have started saying that you can base your metformin level, metformin dose based on the BMI. Earlier, 5-10 years back, Sabahat, everybody used to teach us that metformin, if you give it in a prashad ka dose, it's not going to help. You have to give at least a 1500 or a 2000 milligrams. But that doesn't hold true anymore, I guess.
In
So
fact,
I
I'm
there are
think
not sure
that is
what
studies.
that
Dr.
only
Bhatt's
holds true
view
if
is.
we are giving it in an IVF cycle for the prevention of hyperstimulation. That's where we need an extremely high dose, which is around 2 grams plus,
There are
1.5
That
studies in
also I
which
am not sure, but I would like
there
to
are
hear Dr.
studies
Bhatt's opinion.
there are studies in which they have shown that once you are giving metformin and the fetus develops IUGR, you should stop metformin, because
Okay.
metformin is entering the fetal placenta, is entering the placenta and the brain. Is better in my patients. What I do practically, if they are on metformin, and the one is the BMI, the abdominocentric approach, what you rightly mentioned, and second is the fetocentric approach, where if the patient, the fetus develops IUGR, that time I stop metformin. I don't give metformin that time.
So, but what is the reason that we continue metformin with insulin?
See, metformin is insulin sensitizer. The best insulin sensitizer is insulin itself. But if you are having a large a patient who has a very high BMI, and you are putting in insulin, it's increasing the weight. So metformin is weight neutral. It's not typically weight loss agent, but many patients lose weight clinically. So if you are giving insulin and metformin, it's a synergistic effect. Insulin resistance is lessened, but weight gain because of insulin is neutralized by the weight neutrality or the somewhat weight loss of metformin. And
Got it.
metformin, they have also shown improves labor. It secretes glycodelin from the placenta, and during labor time, they have shown metformin beneficial.
Okay. I think with that, we are kind of wrapping up the session. I would like to thank Dr. Sujata, who has to leave us. She has to catch a flight. She's always on the move. I'm sure she's attending some other. Yeah. Dr. Sujata, thank you so much for being here. And thank you so much for adding to our knowledge. I'm sure the audience is.
Thank you. Thank you so much, Sabahat. Dr.
Thank
Bhat,
you.
it was a pleasure to interact with you. I actually have a flight to catch, so I'll leave.
Yeah.
Sneha is aware.
Have
Yes,
a
yes.
safe flight. Have a safe flight. Thank you so
guys.
much.
Bye bye.
Thank you.
Thank you
Bye-bye.
very much. Thank you very much, everyone. It was very insightful. Being from a non-medical background, I still was able to understand so many things about metformin bariatric surgery. Thank you very much, everyone. Hope to see you again in future also. Thank you very much for your time.
Do we have any questions, Neha?
Yes, we do have few questions. Will it be feasible for you to answer right now?
Yeah.
Okay, just give me a minute. I'll read out the questions to you. We have a viewer who is asking that my period is for more than 7 to 10 days at times. So what is the solution for it? Is it related to PCOS?
No, a prolonged period, my dear, where you have periods extending beyond 7 to 10 days is not usually typical of PCOS. So you will have to look into your thyroid issues, and you will have to get an ultrasound done to have a look at your uterus and to make sure that everything else is okay there.
Okay, we have one more question which says that I got diagnosed with PCOS about 3 years back and I'm 31 years old. Though at times my period gets late by 7 to 10 days, and my menstrual cycle extends to 38 days also. Recently, my cycle was coming for 2.5 months late. So, what should I do? Why my period cycle are so much delayed? Should I visit a gynaec? Is it a PCOS only? Because I have cramps also, and I have acne, body pain, and other symptoms also. Also, in just last 3 months, I have gained 7 to 8 kgs.
So obviously she has PCOS, so she needs to be under the supervision of a gynecologist. For period regularization, it is very important that she keeps her weight under check. She eats healthy, exercises on a daily basis. And sometimes we even need to put them on some kind of medication if there are other symptoms also. So if she is PCOS and she's also gaining weight, it is more of a reason that she has to be assessed in toto. We have to see whether her insulin is okay, whether her sugars are okay, whether her cholesterol is okay, whether her thyroid is okay, whether her, everything else is okay. So she definitely needs to be under the supervision of a gynecologist or an endocrine person.
Thank you so much. Ma'am, the next question says that I'm married at the age of 40 and now we are trying for baby. What should I do to improve my fertility as we are finding it a bit difficult to conceive? Is it necessary that after the age of 40 it is PCOS, or difficulty in conceiving could be other reasons too?
No, age of 40 and PCOS are not related. PCOS is a thing which starts early on and it will continue with you till the end of life. So you will have to get yourself assessed. The most common cause of infertility in this population is high age. And as you age, your ovary ages as well. The eggs get depleted, the quality of eggs really becomes bad. And there are multiple things that affect fertility at this age. So it is better that you see a gynecologist or a fertility specialist ASAP, because 40 is an age at which you really need to be very quick with your treatments, because then the depletion of eggs starts very, very quickly in your ovaries, and then it becomes a very sorry story.
Okay, thank you so much. Ma'am, the last question, it says that our viewer, she is in her mid-20s. She has too much of acne and pimple. She has work stress also. And she has 2 miscarriages, which was a period less than 2 weeks. So what should be the solution for it?
Does she have any menstrual irregularity also?
Well, she hasn't mentioned that, ma'am.
So
She only
obviously,
says she says that she has work stress, too much of work stress, and too much of pimple and acne.
so I think Dr. Hayat can take that question. So maybe she will end up with Dr. Hayat with acne and too much. No, or maybe a dermatologist. But let's her take that question.
Acne is a hirsutism variant, cutaneous variant of hirsutism. So we would see that whether the acne and if there is associated androgenic alopecia and frontal recession or temporal recession, then we have to see whether she is having PCOS. And also, if the cycles, they can have oligomenorrhea. Now, even they have mentioned recently, they can have even polymenorrhea. So, cycle irregularity, acne. So, depending on the grade of acne, hirsutism, frontal recession, temporal recession, PCOS should be ruled out in this patient.
Thank you so much. Ma'am, one more question. I'm diagnosed with PCOS, but my blood sugar levels are under control. So is my fasting. Also, my HbA1c is under control. Still, do I need insulin resistance and metformin?
We'll take that. Dr. Hayat will take that question. But I think in the meantime, Abhijit can start with the post-poll questions.
See, the association of metabolic syndrome and diabetes and impaired fasting is very high with PCOS, especially in obese PCOS. So, metformin acts as a pleiotropic agent in such conditions. Metformin is not only given for diabetes and hyperglycemia. It's being given to you if you have a PCOS for other things rather than blood glucose. But it will help those patients also who have high elevated blood glucose. But as even in lean PCOS patients, we give metformin. So even if you have a normal sugar, HbA1c, and you are overweight and you have PCOD and the doctor has prescribed you metformin, you can continue with it. You have to continue with it.
Okay, fine. That should be all with the questions. Thank you very much, Dr. Hayat. Dr. Sabahat, thank you very much.
So your post poll is done?
Ma'am, we can keep the post.
Started. So can we end the meeting?
Yes, ma'am. I think so. We can end the meeting. We'll keep the poll on for another 5 minutes and then we'll close the polling. Thank you very much, Dr. Sabahat, for giving us such a wonderful and insightful session, ma'am. Thank you very much.
You're welcome. Dr. Hayat, I would like to extend my gratitude. Thank you so much. You are such a busy practitioner. And I was like, I probably will have to remind you. But it was great seeing you had joined the webinar even before me. That speaks of your dedication. Thank you so much, sir.
Thanks a lot.
Thank you so much.
Thank you, Abhijit. Thank you, Vijayata team. Looking forward to having you again.
Sure, ma'am. We too are looking forward to have such a wonderful session again with some more insightful sessions.
Thank you. Thank you, dear.
Bye-bye.
Thank you, ma'am.
Bye-bye. Bye.
Bye-bye.